67-year-old gentleman, farmer by occupation, resident of Alwar, Rajasthan, comes with chief complaints of difficulty in swallowing since 6 months and history of melena, 2 episodes, 10 days back, sir. History of present illness. Patient was apparently normal 6 months back when he noticed dysphagia for solid food with the sensation of food being in the lower chest, which is insidious in onset, initially requiring water along with food, solid food to facilitate the act of swallowing. Gradually, dysphagia has progressed over 6 months, wherein now he can consume only liquid diet. He gives history of regurgitation, especially after consuming solid and semi-solid food. He gives a history of unintentional weight loss over the last 2 months, which is not quantifiable, with an associated history of loss of appetite, and also history of 2 episodes of melena. There is no history of odynophagia, no history of halitosis, neck swelling, or gurgling sound while swallowing, difficulty in initiating swallowing, dysarthria, or nasal regurgitation. There is no history of associated chest pain, postural modification to facilitate food, or relation to temperature of food. There is no previous history of corrosive acid intake, no history of symptoms suggestive of long-standing reflux, no history of hematemesis, no history of cough with expectoration or recurrent upper respiratory tract infection, no history of coughing, choking after swallowing, no history of hoarseness of voice or stridor, no history of backache, no history of abdominal distension, jaundice, hemoptysis, bone pain, blackout or seizures. Past history, patient has no history of tuberculosis, stroke, diabetes, hypertension, asthma, and COPD. Family history, nothing significant. Personal history, patient consumes mixed diet. He has normal bowel and bladder habits. Sleep is undisturbed. He is known smoker for the past 40 years, consumes around 10 BDs per day, and is non-alcoholic. A 65-year-old gentleman, smoker with no comorbidities, comes with complaints of progressive dysphagia, initially for solids, later progressed to liquids since 2 months, with associated significant loss of weight and appetite. Sir, my provisional diagnosis is CA esophagus 1, CA GE junction 2, sir.
With a history of difficulty in swallowing for 6 months and melena, what can you make out in your mind what the patient may be suffering from on the basis of on the chief complaints?
Yes, sir. He is an old man complaining of difficulty in swallowing, sir. Most probably, I would suspect esophageal pathology, sir, with history of also melena. So, I would like to consider a malignant pathology which has bled and caused melena.
So, what are the causes of difficulty in swallowing with melena? In general, what are the causes of difficulty in swallowing in melena?
One, CA esophagus, which I've already discussed. 2, it may be peptic ulcer, sir, long-standing peptic ulcer, which has caused peptic stricture and now bled and caused melena.
No, but how would peptic stricture cause difficulty in swallowing? What do you mean by peptic stricture? Said you should then
long-standing Barrett's.
You should say gastroesophageal reflux disease, GERD, causing acid reflux and peptic esophageal stricture.
Yes, sir. Esophageal stricture.
So in malignant dysphagia, if you have melena also, which indicates GI bleed, what is more likely?
Sir, lower esophageal pathology, sir. Lower esophageal mass. GE junction mass most.
GE junction, yeah. So CA esophagus is less likely to cause melena as compared to CA GE junction. That's what Dr. Nagar also was trying to point out to you.
Yes.
So if you have history of melena, GE junction is more likely rather than CA esophagus. And in this patient, the site of sticking of food also you said is in the lower chest.
Yes.
And as we have discussed earlier, if the food is felt to be stuck at the lower chest, it is unlikely that the obstruction is higher.
Yes,
the other way is possible. That patient says that food is getting stuck in the neck, but the obstruction is at the lower esophagus. Why is this not benign? 6 months history?
Sir, he is a elderly male and known smoker, which is insidious in onset, slowly progressive over time.
Yeah. So painless progressive dysphagia is more likely to be malignant. If the history is slightly long, in benign obstruction, especially achalasia, you will have intermittent dysphagia and other features which you described in the negative history also, relationship to the temperature, posture, and other. Yeah, Anand, please carry on.
The first thing, the concern of the sir was the site of the sticking of the site of the obstruction in the esophagus, a site of the obstruction in the chest. In the soft way, we can say is in the text says is usually doesn't correlate with the site of the obstruction of the. So it can suggest towards the site, but it's not always possible that the site of the obstruction is there. Okay.
Yes, sir.
Now, so on the basis of as the dysphasia you have described, can you tell me the grading of the dysphasia?
Yes, sir. Initially, it was grade 2, sir. Now it is grade 4. Grade 2, patient needed some liquid with solid food, sir. But now patient is able to tolerate only liquids. Grade 4.
So who gave this terminology of the grading of dysphasia? You should know.
By
Is
whose
that-
name? By whose name does it go? I think it is Takada.
Takita.
Even sir,
Yeah.
so you should know that the grading of dysphasia given by whom.
Yes, sir.
Even very early I read this.
To go around.
Okay.
Yes,
We
sir.
can ask the grading of dysphasia.
Yes, sir.
By whom we are given. Takeda, sir, it was confirmed that Takeda given the terminology.
Takeda, yes.
In the negative history, why did you ask this odynophasia? So first of all, what is the difference between reflux and the regurgitation? You have told that the regurgitation of the food.
Yes, sir. Sir, regurgitation is effortless expulsion of food, which is undigested
Okay.
just after having food. And reflux is something like patient will feel sore water brash kind of thing in the chest. That is
So
reflux.
whether regurgitation of the feature of the another disease also can suggest me. You can tell me the regurgitation in the other features, other disease also.
Okay.
Achilles.
Yeah. So, and just explain all the negative points which you have asked for the sake of your students. Why
Yes,
did you ask all these
There
points?
is no history of odynophagia, sir, which I'm thinking in terms of pharyngeal obstruction. I want to rule out pharyngitis, tonsillitis kind of picture, sir. And halitosis, neck swelling and
What is,
gurgling,
sorry, wait. What is odynophagia?
painful swallowing, sir. Pain during act of swallowing, odynophagia.
Only tonsillitis, nothing else? Any
Pharyngitis,
Okay.
esophageal candidiasis, sir.
More common than that, esophageal candidiasis. Any
Common cold.
inflammatory
Common cold.
Any inflammatory pathology in the esophagus will cause odynophagia. So if you have severe reflux esophagitis because of the edema, because of the spasm, and then at a later stage because of some formation of a stricture, that will cause odynophagia. So any inflammatory disorder of the esophagus will cause odynophagia. Once a definite peptic stricture forms, then because of the stricture, there is no reflux, so there is no esophagitis. Then there may not be odynophagia, but in the initial stages of reflux esophagitis, there may be. On the other hand, a simple mechanical obstruction like malignancy or a functional obstruction like achalasia, it will be painless. Next.
Halitosis, neck swelling, or gurgling sound while swallowing. This I want to rule out Zenker's diverticulum, sir. Next, difficulty in initiating swallowing, dysarthria, or nasal regurgitation. This I would see in
What do
bulbar
they indicate? Yes.
palsy, sir. Associated chest pain, postural modification to facilitate food, and
No,
relation to
sorry.
temperature
So
of food.
difficulty in initiating dysarthria and nasal regurgitation, what do they indicate?
Palsy, sir. Motor palsy.
So upper pharyngoesophageal
Pseudobulbar palsy.
disorder or muscular weakness causing dysphagia.
Associated chest pain, postural modification to facilitate food, or relation to temperature of food. Here, I would like to rule out gastroesophageal motility disorders, sir. DES and Nutcracker syndrome.
Okay.
Achalasia.
So which motility disorder is more likely to have pain?
Nutcracker syndrome.
Yeah, diffuse esophageal spasm rather than achalasia. Achalasia is usually painless. Some patients with achalasia, when there is stasis of the food, which then causes stasis esophagitis, may have pain, but that is more like odynophagia. Whereas patients with diffuse esophageal spasm, they have this typical what is called as a mediastinal colic, because this is episodic pain, which is severe pain. It comes suddenly and goes off on its own because of the spasm of the esophageal musculature. Next.
No history of corrosive acid intake. No history symptoms suggestive of long-standing reflux. No history of hematemesis. No history of cough with expectoration or recurrent upper respiratory tract infection. No history of coughing or choking, sir. Sir, corrosive acid intake. Should I
That's okay.
explain everything, sir?
So this no history of coughing or choking after swallowing, what are you trying to indicate?
Sir, tracheoesophageal fistula.
So after swallowing what?
Liquid
Liquid. So you should have
specifically.
added that. No history of coughing, choking after swallowing, especially liquids. So then I don't have to ask a counter question.
No history of hoarseness of voice or stridor. This occurs with recurrent laryngeal nerve invasion, sir. And sometimes chronic cases, laryngeal edema caused by reflux of the gastric contents also causes hoarseness of voice.
Backache.
Backache, invasion, vertebral invasion, which I'm looking for, sir. No history of abdominal distension, jaundice.
Backache in CA esophagus can be because of direct infiltration of the posterior parietes, especially the vertebrae, when it will be localized to that point. So you should say no history of pain in the back of the chest or in the thoracic spine. On the other hand, you can have backache anywhere because of vertebral metastasis, which could be at a distant place also.
No history of abdominal distension, jaundice. I'm looking for ascites, sir. And jaundice mostly due to nodal metastasis causing compression of the CVD. Hemoptysis causing due to lung metastasis, which may cause erosion into the vessels. Bone pain, which is local infiltration into the vertebrae or distant infiltration. Blackout or seizures, suspecting cranial.
Yeah, so again, the typical metastatic history for liver metastasis usually do not cause jaundice unless there is a large deposit sitting right at the hilum of the biliary ductal confluence, or most of the liver parenchyma is replaced by multiple bilobar metastasis. So the commonest manifestation of liver metastasis is just anorexia and weight loss, which could be there even without liver metastasis. Ascites is fine. Jaundice, if at all, is there in an intra-abdominal malignancy, it is more likely to be due to, as you rightly said, nodes in the porta hepatis or hepatoduodenal ligament causing external compression of the common bile duct. Lung metastasis usually would not cause hemoptysis to begin with. The commonest manifestation of a pulmonary parenchymal metastasis is just persistent dry cough. Later on, yes, when it erodes into the bronchus, it can cause hemoptysis. Bone pain is fine, and more important or more direct questioning is any history of a spontaneous or pathological fracture following trivial trauma. Similarly, intracranial metastasis is recent onset. Bone pain also same way, recent onset, persistent, moderate to severe headache, and then other features like blackout, seizures, or altered sensorium. So recent onset, moderate to severe bone pain, recent onset, moderate to severe persistent headache. These are the earliest features of bone and brain metastasis.
Coming to past history, there is no history of tuberculosis.
Okay, that's fine. You've already done this. Yeah, carry on. Yes.
Family history, nothing significant, sir. Personal history, patient consumes mixed diet. He has normal bowel and bladder habits.
Yeah.
Sleep is undisturbed. Smoker for the past 40 years. Consumes around 10 BDs per day and non-alcoholic.
Yeah, come to the summary.
65-year-old gentleman, smoker with no comorbidities, comes with complaints of progressive dysphagia, initially for solids, later progressed to liquids since 2 months, with associated significant loss of weight and appetite.
I would put CAG junction first and CA esophagus later, as I was trying to explain to you that if there is a history of melena, then stomach involvement is more likely. So in this case, because there is dysphagia, CAG junction, which is in causing dysphagia as well as bleed rather than CA esophagus. Both are possible, but I would put reverse the order. Yeah,
yes, sir.
Please carry on.
Coming to general physical examination, my patient is well built but poorly nourished, alert, conscious, cooperative, oriented to time, place, and person, lying comfortably on bed with ECOG 3. His BMI was 16. He is afebrile. Pulse rate was 78 beats per minute. Blood pressure was 128 by 76 millimeters of mercury. The saturation was 98% at room air. He was taking around 15 respirations per minute, and breath holding time was around 30 seconds. There was no pallor, no icterus, no bilateral supraclavicular lymph nodes or neck nodes, no clubbing, no cyanosis, and no pedal edema. And there were no signs of dehydration also, sir. On examination, oral cavity, adequate mouth opening was present with poor dental hygiene and nicotine-stained teeth. No mucosal lesions were seen.
What mucosal lesions you were looking for?
Sir, leukoplakia, erythroplakia, because he is already a known smoker.
Yeah. So patients with oral cancer and patients with upper aerodigestive tract cancer are very likely to have either synchronous multiple cancers in the entire aerodigestive tract or metachronous. So if a patient has CA esophagus today, you have treated, he or she is more likely to have another cancer. And in fact, some people would do what is known as a triple endoscopy as a routine. Upper GI endoscopy,
Bronchoscopy,
bronchoscopy, pharyngolaryngoscopy to look at synchronous lesions. So as a routine, all patients with squamous cell carcinoma in some units will have this evaluation.
Coming to abdominal examination, abdomen is flat, umbilicus is central, midline is midline and inverted. All quadrants are moving equally with respiration. No visible lump, scar, sinus, engorged veins, pulsations, peristalsis, or cough impulse. Bilateral renal angles, there was no fullness noticed. Hernial orifices are intact. Coming to palpation, all inspectory findings are confirmed. No local rise of temperature or tenderness noticed. No organomegaly, no palpable lump. Hernial orifices on examination were normal. Bilateral renal angles were non-tender. On percussion, there was no free fluid. Liver dunnel started at fifth intercostal space and liver span of 14 centimeter in right midclavicular line. Rest of the abdomen is tympanic. On auscultation,
in a patient with dysphagia, what lump you were looking for in the abdomen? You said no palpable lump.
Sometimes a huge mass at G junction, sir, would be palpable. So I was trying to see for the mass palpable.
Any special maneuver which you should have done and you should have mentioned? You have to make the patient stand up and palpate in the standing position. A mass may not be palpable, a lump may not be palpable in the supine position, but especially in a thin-built patient like his BMI is 14 or 16, elderly person whose muscles are lax, if you make the patient stand up and then do a deep palpation in the epigastrium, you may be able to feel a mass which is not palpable in the standing position. So you should specifically mention that I palpated after making the patient stand up. And anything else you can palpate as a lump?
Lymph nodes, maybe, sir.
It could be a nodular hepatomegaly, of course, you would describe as a hepatomegaly. It could be a large peritoneal or omental deposit. It could be a large nodal mass. Theoretically speaking, these are all possibilities, especially, as I said, in a elderly person with lax muscles and very low BMI.
On auscultation, normal bowel sounds were heard. On this DRE, sphincter tone was normal, no external abnormalities, normal fecal stool staining was present, and no nodules were felt.
Findings should be present in chronological order. You would notice the external abnormalities first.
Yes, sir.
So, and what is the difference between digital rectal examination and what do you mean by digital rectal examination?
My rectal examination findings, sir.
So it's basically palpation only, isn't it?
Yes, sir.
Palpating the inside of the rectum and anal canal with your finger. And complete rectal examination would include inspection, which is inspection of the perianal area, and a proctoscopic inspection of the anal canal and the rectum. They are not synonyms. And the sequence would be no external abnormalities, then sphincter tone, then nodules, and then the finger stall. Because finger stall you will see only after you've taken your finger out. And wherever relevant, you should always say that either I wanted to do proctoscopy or I did proctoscopy. If you could not do, you should say what you would like to see on. And again, no nodules felt. Where exactly were you feeling trying to feel the nodules? What do you mean no nodules?
Bloomer shelf, which is anteriorly
in the rectovesical pouch.
rectovesical pouch.
Again, whatever you describe, whether positive or negative, you should give a complete.
Coming to respiratory system, on inspection, trachea is central in position. Bilateral chest movement is normal. No engorged or dilated veins noticed over the chest. On palpation,
In a patient, okay, please carry on.
on palpation, trachea is central in position. Bilateral chest movements were equal. Normal tactile vocal fremitus is present. On percussion, resonant note is present in bilateral lung fields. On auscultation, bilateral air entry is equal with normal vesicular breath sounds. No decreased breath sounds or added sounds were heard.
What chest findings you were expecting to find or you were looking for seriously?
Sir, one I was deviation of trachea, sir. I was looking whether it is center or not.
Why should trachea be deviated?
Huge masses will push the
Esophageal mass, why would it trachea to one side?
I thought of seeing lung pathology also, sir. Long stand.
So what were you?
Fibrosis and tracheal shift.
Why should there be fibrosis in the lung in dysphagia? So go back. What were you actually looking for? This is a patient who has dysphagia. He has history of regurgitation. What is the commonest pulmonary or chest finding?
Pleural effusion and aspiration pneumonitis.
Pneumonitis. Aspiration pneumonitis, so it will be crepitations, especially at the bases of the chest. Pleural effusion is not because of regurgitation. Pleural effusion is malignant pleural effusion or nutritional pleural effusion. But nutritional pleural effusion is more likely if there is pedal edema, if there is ascites. We didn't find any pedal edema or ascites, so unlikely that it will be nutritional pleural effusion. Yes, malignant pleural effusion, which is more likely to be unilateral rather than bilateral. How do you detect pleural effusion on clinical examination?
Sir, I would dull note would be present on the lower lobes, sir.
So what findings suggest that?
And on auscultation also, lower lobes, I wouldn't hear decreased breath sounds in the lower lobes.
So decreased breath sounds will be present probably in collapse. What is the typical finding of pleural effusion on chest examination? Suppose there is massive unilateral pleural effusion. What will be the finding?
Breath sounds, sir. Massive.
So starting from inspection and palpation, the movement will be restricted as compared to the other side. And more important or very important finding is the dull note on percussion. And then, of course, the breath sounds will be decreased. So that is how you detect pleural effusion. Because in any patient with dysphagia, these are the two important findings. If it is malignant dysphagia, you are looking for pleural effusion. And if there is history of regurgitation, you are looking for aspiration pneumonitis. Pulmonary metastasis usually would not cause any clinical findings unless there is a metastasis which is pressing on a bronchus and you can hear rhonchi. Otherwise, they are just found on imaging.
Other systemic examination, CNS and CVS are normal, sir. To summarize, 67-year-old gentleman.
There's no problem about the diagnosis. Now, what will you do?
Sir, initially, I would like to get two sets of investigations, sir. One to assess the patient and two to diagnose my disease. One, baseline investigations, I would like to get CBC, LFT, RFT, viral markers, PT-INR, and C, sir, first. And as an to diagnose the disease.
In routine investigation, 67-year-old gentleman, chronic smoker, nothing else you want?
I would like to see chest X-ray also, sir.
Chest X-ray, and considering his age, his cardiac evaluation also.
Yes, sir.
So that also becomes part of the first set of investigations. And in all patients with CA esophagus who are going to have surgery, you have to mention pulmonary function tests, and some people would actually include an ABG also to look at the oxygenation. But at least SpO2, which you already mentioned, breath holding time and SpO2, but chest X-ray and pulmonary function test is more so because he's a heavy chronic smoker. Okay, for diagnosis.
For diagnosis, I would like to first consider ultrasound of.
How would ultrasound give you a diagnosis?
First, I would like to do endoscopy, sir.
By and large, all patients with hepatopancreaticobiliary disorders, the first investigation is an ultrasound. in all patients with a GI disorder, especially dysphagia, rectal bleeding, or colonic bleeding, it is an endoscopy which is usually the first diagnosis. And whenever you say endoscopy, if you're suspecting or your diagnosis malignancy, you have to say endoscopy and biopsy. Let's see.
Coming to blood investigation, sir, his hemoglobin was 9.5 grams per deciliter. TLC was 10,000.
No need, no
yes,
need
sir.
to read the numbers. Give your interpretation.
He has mild anemia, sir, and bilirubin was normal. Albumin shows malnourishment. Other liver enzymes were within normal limits. His RFT, creatinine
Albumin
was normal.
sorry, albumin is normal.
3, sir. He's malnourished.
Yeah, sorry, I heard it wrong. Yes, then
Serum creatinine is 0.7, sir, almost within normal limits, but mildly raised urea due to dehydration, and he has not been taking food since 2 months, so maybe because of that. And sodium is 138, potassium is on the lower side, hypokalemic 3.4, chloride is within normal limits, INR is normal, sir. Viral markers were negative.
urea
Was slightly raised, sir, because of dehydration.
Yeah, so you should have said that his urea is slightly higher than normal, although his creatinine is normal. So most likely he is dehydrated, pre-renal. Show the endoscopy first.
Yes, sir. Sir, his endoscopy showed ulceroproliferative growth extending from 35 centimeters of upper incisors till 2 centimeter beyond GE junction, sir.
So what does that?
Significant remular narrowing and scope negotiated with difficulty.
So what does that indicate?
Actually, it is a morphology was described, sir, ulceroproliferative, and it is at the GE junction, around 35 centimeters, and also involving GE junction and beyond GE junction for 2 centimeters.
Repeat.
So it is GE junction mass.
You have already said. What do you make out of this?
And it's a GE junction mass.
This is a GE junction growth, most likely a type 3 growth because it is extending on both sides of the GE junction, isn't it?
Yes, sir.
It's going into the stomach and it is in the esophagus also. It is straddling the GE junction. So most likely the epicenter is in the type 2. No, this will be type 2.
Type 2,
Type 2.
sir, actually.
Type 2. Type 2. Yeah.
Yes, sir. But biopsy was reported it to be squamous cell carcinoma, sir. So we can't use C word for this. So
that's unusual because squamous cell carcinoma usually does not cross the G junction to involve the proximal stomach.
Yes,
so there is a discrepancy. Either the endoscopy finding is not correct or we need to review. Although if they have said squamous cell carcinoma, show the histopathology report. How do you diagnose squamous cell carcinoma on histopathology? What are the characteristic features?
Keratin pearls.
Yeah, they haven't mentioned keratin pearls, and I'm sure there are some IHC tests. But they have said squamous cell carcinoma, it is unlikely that it is adenocarcinoma.
Yes,
unless they say poorly differentiated. Poorly differentiated, it may be difficult to differentiate. In fact, whenever you get the report of a poorly differentiated adenocarcinoma, you have to keep a lymphoma also as a possibility because without immunohistochemistry, it is not possible. So since histology is more reliable, you start suspecting whether the endoscopy report is correct, the evaluation is correct, that it has gone into the stomach. Squamous cell carcinoma is adenocarcinoma can involve both esophagus and stomach, but squamous cell carcinoma is usually confined to the esophagus. Okay, what next?
Sir, after the biopsy, I would like to see initially evaluate the patient with ultrasound and chest X-ray, sir, to look for metastasis.
Let's see.
Yes, sir. Sir, ultrasound report was normal, sir, with minimal free fluid in perihepatic, perisplenic, and Morson's pouch and pelvis with mild ascites.
Are you worried about it?
No, sir, not really, because patient is already malnourished. So it may be nutritional. It may be metastatic also, which I would like to do a abdominal tap and consider for cytology, sir.
So again, a squamous cell carcinoma is less likely to give rise to either liver metastasis or nodes in the porta hepatis causing jaundice or ascites. On the other hand, an adenocarcinoma, either of the GE junction or of the stomach, is more likely to produce these metastases. And that is why uh, in squamous cell carcinoma, staging laparoscopy is usually not recommended. Whereas if you are dealing with an adenocarcinoma of the GE junction, many groups would do a staging laparoscopy. So since this is squamous cell carcinoma, patient is malnourished with a low BMI, significant loss of weight, and his serum albumin is 3, it is more likely that this fluid is nutritional rather than metastatic, although in the absence of pedal edema, because if we say that this is because of hypoalbuminemia, then he should have had some pedal edema also. And we still don't know whether he has fluid in the chest. Let's see the chest X-ray.
The chest X-ray was normal, sir. I couldn't get the
No pleural effusion.
no pleural effusion. I would like to show it in CT, sir.
Yes. So that again suggests that, because if you have only ascites and the patient doesn't have pedal edema or pleural effusion, and if the serum albumin is not very low, then you start thinking whether the ascites is metastatic. Yes. Next.
Next, I would like to get a CT done, sir. Sir, I would actually, my patient is ECOG 3, sir. Not fit for surgery now. So I would like to get PET CT, sir.
Why?
In this patient, I would like to manage the patient because the patient is not fit for surgery, sir. I would like to see for any metastasis and initial staging of the disease with PET scan. And
So presence or absence of metastasis is important in a patient who is not fit for surgery or in a patient who is fit for surgery. If he is not fit for surgery, whether he has metastasis or not, it doesn't make a difference. Metastasis is more important if you are planning to operate, because obviously you will not operate if there are metastasis. So your answer is other way around. I fully agree with you, and I'm very happy that you made that statement that my patient is not fit for surgery, because he is performance status is 3, his nutritional status is compromised. We haven't yet looked at his pulmonary function, but that may be bad. So BMI is very low, and most probably he is not a fit candidate for surgery at the moment, at least.
yes, sir.
And that is why doing these investigations at this stage probably is not going to change your plan of management.
Yes.
So what suppose you also feel, and suppose the anesthetist also says that no, we cannot take up this patient for surgery, then what would you do?
First,
And
I-
before
First, I
that,
would,
is surgery the only option of treatment?
no, sir. We can give definitive chemoradiotherapy.
So you should have said that he, because of these reasons, he is not a candidate, or he is not a good candidate, at least for surgery. But because this is a squamous cell carcinoma, I have another option of treatment, which some reports say is equally good. There are reports which have said that for squamous cell carcinoma, definitive, not neoadjuvant or
Yes,
not palliative, definitive chemoradiotherapy is as good in terms of survival as surgery. So in a patient who is not fit or who is plus minus fit for surgery and histology is squamous cell carcinoma, you have another equally good option of treatment. So the treatment of choice in this particular case would be definitive chemoradiotherapy, and more so because at the moment you said he is able to swallow liquids. So nutrition is not a problem. You can give him a liquid diet, a full calorie, full protein liquid diet, and start him on chemoradiotherapy. Let me ask a theoretical, hypothetical. Suppose he had absolute dysphagia.
Yes, sir.
Same patient, he had absolute dysphagia. He's not able to swallow even saliva. Then what would you do?
Sir, firstly, I would like to do endoscopy and guide wire. I would like to pass a guide wire and pass a Riles tube feeding. Try for it, sir. One.
So the first thing which you need is a nasogastric feeding tube, which is possible if just a guide wire goes, because once a guide wire goes, you can dilate and you can then put a feeding tube. Suppose guide wire doesn't go.
Sir, then I would like to do a dilatation and then pass guide
How
wire.
will you do dilatation if a guide wire hasn't gone? You need, for any dilatation, you need a guide wire, because all the dilators, whether they are solid or balloon, they go over a guide wire. You can't push a dilator just blindly. So what will you do? What are the options if a guide wire also doesn't go?
I'll do FJ, sir. Feeding jejunostomy.
The endoscopist cannot do anything else.
Sir, they can do PEG. But as it is not passing through the mass, we can't do PEG.
In a non-passable growth, are there any endoscopic options of re-luminalization?
Yes, sir. Ablation techniques.
You can do ablation, isn't it? So they can do tumor ablation, which can be initially it used to be cautery. I don't think now anybody uses cautery, but laser.
Radio
what else?
frequency ablation.
RFA करते हैं esophagus में नहीं laser mainly laser. So you can so you can ablate the tumor and create a path. Any other non-surgical option to create a path in a non-passable growth? So Dr. Vinay Mahala is telling you, see, one is ablation of the tumor by these means, and second is radiotherapy.
Yes.
Squamous cell carcinoma radiotherapy. So it could be endoscopic endoluminal brachytherapy, which will open the lumen, and even external beam radiotherapy in a squamous cell carcinoma, maybe in a few cycles or few sessions only, can open up the lumen. So you have various options before you think or resort to a feeding surgical. So suppose all these things are not available or they don't work, what feeding surgical procedure you have in mind?
Yes, sir. Feeding jejunostomy, sir.
Why jejunostomy? Why not gastrostomy?
Sir, I would like consider is for stomach pull-up, sir, after esophagectomy. So I would like to save stomach for my surgery.
So does a feeding gastrostomy contraindicate a gastric pull-up?
It is not a contraindication, but it would distort the anatomy. So I would like to do jejunostomy, sir.
Yeah, so most textbooks do mention, I think I have also mentioned it in my
Yes,
book, but if you create a proper feeding gastrostomy, where do you create it?
Maybe in the body only, sir.
In the mid-body between the greater and lesser curvature. That is the ideal point, isn't it?
Yes, sir.
So yes, it will distort the anatomy because obviously you will fix the stomach to the parietes, so you have to detach it. There will be a hole in the stomach which you will have to close. Some people feel that it will shorten the length of the stomach, but I don't think it does really. And if you are creating a tube of the stomach to be pulled up rather than using the whole stomach, then anyway it doesn't matter. So it's not really a contraindication, and I'm sure many groups probably would be doing feeding gastrostomy, but yes, most people don't want to touch the stomach in case the patient is a candidate for future surgery where you are going to use the stomach as a conduit. So in a patient who is not fit for surgery, especially if it is a squamous cell carcinoma, you have the option of placing a nasogastric tube for feeding, if it is possible. If not, you have options of endoscopic luminalization using laser, using brachytherapy, using external beam radiation, and improving the nutritional status of the patient. Okay. And in fact, any feeding port would be required even if the patient is going for chemoradiotherapy also, because you want the patient to be in the best of the nutritional status. So squamous cell carcinoma, always, even if the patient is fit for surgery, you have to mention that you would explain both the options to the patient and why you are choosing surgery. So let me come to that. Suppose he was a 50-year-old gentleman who had good performance status, reasonably good nutritional status. He was fit for surgery. Then what would you choose and why?
Sir, first I would like to do CT and see the resectability, sir.
Okay, resectable lesion. We'll come to the CT later.
Yes, sir.
Let us finish
If
that
it is
debate.
a resectable lesion, then I would give him two options. As it is squamous cell, I would give him an option of surgery and option of definitive chemoradiotherapy also, sir.
So in which situation you would not give these options and say that no, for you this treatment is better, either definitive chemoradiotherapy or surgery? Squamous cell carcinoma.
Squamous.
Any squamous cell carcinoma where you would say no surgery, definitive chemoradiotherapy. Even as a surgeon, you would say that. Location of the tumor?
Cervical, I would like to go with the definitive chemoradiotherapy.
Most groups would not do surgery for cervical esophageal cancer. Why? Why not?
Because there is almost very good results with chemoradiotherapy.
Sorry, we lost your sound. Say again.
There are very good results with radiotherapy, sir, chemoradiotherapy for upper esophageal cancers.
No, response is same whether it is upper or lower. Why surgery is not preferred by almost all groups?
The vitals,
Because it will entail a very high
structures around.
It will entail a very high. It will entail almost a pharyngeal anastomosis. And if the tumor and in squamous cell, you need at least 5. Some people say even 10 centimeter proximal margin because of the intra mucosal lymphatic spread. Plus, if the tumor is very close to the larynx, then it may entail a laryngo esophagectomy, which will mean a permanent tracheostomy. So, for cervical esophagus, most groups or almost all groups will go for definitive chemoradiotherapy. Even for upper, that is supracarinal esophagus, those who are not very aggressive in their surgical approach to squamous cell carcinoma, they would say we would go for definitive chemoradiotherapy. But for infracarinal, both are equally good options. And what is the advantage of surgery over definitive chemoradiotherapy? Theoretically speaking, at least.
We can remove the bulk of the disease, sir.
Yeah, basically lymphadenectomy and proper staging for prognosis and so different groups. I think you need to read the reports. There is a very good review done by Dr. Murugappan with me on role of adjuvant therapy, neoadjuvant, definitive, and adjuvant in carcinoma esophagus. All of you send me a mail, vkkapoor.india@gmail.com, write adjuvant therapy in esophagus. I'll send you that article. It's a very good review which we did about, I think, 2 years ago, which reviews the entire literature about neoadjuvant and adjuvant and role of definitive chemoradiotherapy. So suppose squamous cell carcinoma, you have given definitive chemoradiotherapy. How do you monitor?
Sir, I would do repeated CT scans, sir, at every 3 months for 1 year and 6 months for 2 years and thereafter every year.
Only CT?
I would also like to consider endoscopy. And
so you, for any non-surgical treatment, whether it is definitive or neoadjuvant, you should start by saying clinical.
Yes.
First is relief of dysphagia. The second easiest is endoscopic. And at the time of endoscopy, a biopsy, so histological. Then comes anatomical, which is CT scan. Then comes biological, which is PET scan. In fact, I think NCCN guidelines now recommend PET scan in squamous cell carcinoma esophagus, whether you are going for definitive, neoadjuvant, or upfront surgery as a baseline for monitoring. And in other tumors like pancreas, biological would also indicate tumor markers. So any response to non-surgical treatment, these are the features which you should say: clinical, endoscopic, histological. In histological, you have, how do you assess the histological response to either neoadjuvant or definitive treatment? What is it called?
Mitotic rate. There are 4.
TRG, tumor regression grade.
Yes, sir.
There are grades described. You compare the current histology with the pre-treatment histology. And depending on what you see on histology, I don't remember the details, but it is called tumor regression grade. And then biological, as I said, PET scan, and wherever relevant, tumor marker. So that should be the complete answer when you say. Let's see quickly the CT scan. Yeah, show the important
yes,
area only.
1 second, sir. కీనోట్లోకి వెళ్ళిపోను. కీనోట్ ఏది ఇదే మార్చావా ఫొటోస్ కనిపిస్తుంది చూడండి సార్. 1 సెకండ్ సార్, దేర్ సమ్ ప్రాబ్లం. కనపడట్లేదా? భయంకరమైన ఫొటోస్ ఉన్నాయి.
Okay, maybe you can show it to us in the next session. Briefly, what would you like to look for in this particular case on CT?
Sir, I would like to see the location of the mass, sir. The length of
that you know from endoscopy.
But yes, sir. And I want to know the length. And I want to know.
Is length important?
Yes, sir. More than 8 centimeter is considered a non-surgical candidate and chemoradiotherapy.
It was mentioned in some books, but most people feel that length is not that important. Although yes, there will be some relationship of the length to the circumferential spread, but length alone is not important. It is the circumferential spread.
And I would like to see the relation with the aorta, sir.
So this is a infracarinal growth, isn't it? It is at the GE junction.
Yes,
So
sir.
here, trachea and even left bronchus are far away. We are not concerned with them. So most important structure for a GE junction growth is aorta and
I would like to see liver mets.
what makes it unresectable? Involvement of what structures, and involvement of what structures doesn't contraindicate resection.
Sir, azygos is not contraindicated, whereas IVC invasion is again considered unresectable, but it is very unlikely. It is almost to the left.
So what is 4A and what is 4B? T4A, T4B.
4A is involvement of peritoneum, pericardium.
Pericardium, pleura and crus. Pericardium, pleura and crus is 4A.
Yes, sir.
But they don't make it unresectable. So you can take care of them. 4B is aorta, vertebra, and tracheobronchial tree. So as I said, this is a GE junction growth. So here tracheobronchial tree is not important. It is basically aorta and the posterior parietes, that is vertebra. So that is what actually you are looking for. Rest, everything is kind of immaterial. The other thing you can say is the thickness which is involved, for which CT is not a very good investigation, and the lymph node, because that is what is going to decide whether you will give neoadjuvant treatment or not.
Yes.
So if it is a relatively early growth, then after the CT scan, you may have to do an endoscopic ultrasound, especially if the growth is passable, because that is what will decide whether the patient is fit enough, if it is very early, for endoscopic management, and if it is relatively early, then for upfront surgery. Because if it is T2 N0 growth, then you may not give neoadjuvant treatment, you may go for upfront surgery. But by and large, most patients who come to us with significant dysphagia, they are not early. They usually have T3 or T4 disease, nodes are positive. So most of them are candidates for neoadjuvant. So if you want to continue with the management of CA esophagus and CA-GE junction, let Dr. Anand know. You can prepare a small presentation that indications of surgery, types of surgery, contraindications and procedure, and then we can discuss the operative surgery part also. Okay?
Yes.
So, Dr. Anand. And if you are free, call me anytime after 12.
Yes,
You
sir.
have my number?
Yes, sir.
Yes, call me after 12.
Yes, sir.
Thank you. Thank you.